Morning, everyone. I'm Doug Story from the Center for Communication Programs at the Johns Hopkins Bloomberg School of Public Health, and I'm honored to be moderating this first panel this morning. In this first session, we're going to try to lay some groundwork for the discussion that we will have over the next day and a half. We have a distinguished group of panelists who are going to lead us through some initial thoughts about the capabilities and capacity for risk communication, how to do effective communication. We're going to look at some of the foundational research in decision sciences that tell us something about how communication can be effective. And we're going to hear about some of the methods that can be used to research and evaluate communication programs to develop strategies that are likely to be effective. As Jeff and David have already suggested this morning, this is an interdisciplinary group of experts that we've convened here. We know that innovation often happens at the boundaries between disciplines. And communication and public health themselves are what I think of as boundary disciplines. Communication and public health are both grounded in very diverse theoretical, academic, conceptual origins. And so bringing those two together, mashing them up and seeing where we can find opportunities for innovation and creative insight will be part of, I hope, what we do over the next day and a half. Risk communication itself is a kind of bridging domain of research and practice, where the biomedical and the social and behavioral sciences come together. So I'm very much looking forward to hearing what our first three panelists have to say about some of these foundational ideas that will shape our thinking about risk communication. Our three panelists in this session are Dr. Baruch Fischhoff from Carnegie Mellon University, who I believe is probably known to many of you. He's had a distinguished career as a member of the National Academy of Medicine, founding chair of the Food and Drug Administration Risk Communication Advisory Committee, and has served in an advisory role on numerous U.S. and international agencies and commissions, including several National Research Council committees, National Academies of Sciences, Homeland Security, and the EPA. Dr. Angie Fagerlin from the University of Utah is the chair of the Department of Population Health Sciences, and is a research scientist with grounding in experimental cognitive and social psychology. Her research focuses on testing effective methods for communicating medical data to patients and providers, and understanding the decision science behind communication between patients and providers, and communicating information about complex scientific issues to the general public. The third speaker is Dr. Gary Krebs from George Mason University. He is the director of the Center for Health and Risk Communication at that university, and has a long career of research in health, risk, and crisis communication, particularly with an eye toward understanding inequities in the way that we are able to reach people and serve them with communication effectively. He was the founding chief of the Health Communication and Informatics Research Board, research branch at the National Cancer Institutes, where he worked for a number of years planning national research programs to promote cancer prevention and control. And he has served on the faculty at a number of universities around the country, and he will talk to us about methods for evaluating and measuring communication effects. So with that, I will introduce our first speaker this morning, Dr. Baruch Fischhoff.
Well, I'm very pleased to be here. I thank this community for your brave and important work, and I thank the forum for inviting me, and I thank the forum for choosing this topic of capacity building. I think it's clear already from the program, and will be clear from the from the rest, that we know a lot about the pieces of this puzzle, but there are a lot of pieces to this puzzle. They need to be tailored to the circumstances of diverse populations in diverse countries. We need a standing capacity to deal with long-running problems. We need surge capacity to deal with it, and we always need to deal with emerging infectious diseases, and we need there are new theoretical problems that come along. So, let's see. Let's see. Yes. So what I thought I would do is to try to frame this capacity that we need. And I thought it could be organized in terms of these 5 questions. What information do we need in order to communicate about infectious diseases? What science do we need to acquire that information? What people do we need to apply that science? What organizational structures do we need to coordinate those people? And what commitments will take to make that happen? So first, what information do we need to communicate about infectious disease? So again, as noted by the previous speakers, the public may need to know things like for a particular disease, how severe it is, how transmissible it is, where is it found, how effective are different protective measures, how practical are different protective measures given their personal and family circumstances, and then who are these people that they're suddenly in their face, and we need to decide who to trust and who not, which news is real and which news is fake. From the public health community, we need to know for each of these diverse populations that we're trying to serve, what do they believe? What are the concerns on their mind? What resources do they have? What experience do they have at the moment or in the past that they're trying to use to interpret the current situation? Who are their preferred information sources? What are their preferred information channels? And then who do they trust in providing this information? And that can be different for each of these populations and can be different for each threat and can be different in the dynamics of a threat. So what science do we have to acquire that information? Well, as will be apparent, we have a lot of science, and from this is for this program, you'll see a lot of that science. From a decision science perspective, the discipline with which I identify, the way we look at communication design is in a sense to do what other people do, anyone does naturally. There's a question, you first begin with analysis, identify the facts relevant to the choices that people face. Descriptive research to determine what people want and believe, interventions designed to fill the critical gaps, evaluating what you do, as Dr. Rainford said, and then repeat that as necessary, because you never get it right the first time. So the people with whom I've worked have applied this general approach or paradigm to a wide variety of topics, including some infectious diseases. So the science base for learning about the public's needs is in fact vast. The question is really capacity building for how to use it. I thought I would feature a few things that come from this institution, which has been a pioneer in developing the science. There was an Academy report in 1989 on improving risk communication. I've had the opportunity to help to organize 2 Sackler colloquia. There's a third in the offing on the science of science communication that have free for download issues of PNAS. I've put the URLs for most of the material that I have here, if it's not familiar to people. There's the first. There's the second. I had one piece, and I'll put in a plug for a piece I had in the first, giving a general overview, and a piece I had with Alex Davis on how to communicate about scientific uncertainty, which was just been mentioned. Perhaps less familiar might be the science base of deriving the information that the public needs, because often you need to know things for which we don't have established science. We're trying to integrate knowledge from diverse sources in order to answer the public's questions. Within risk analysis, there's an area called expert elicitation. There's this very nice piece by Granger Morgan in PNAS from about 2 years ago about how to ask the experts to synthesize the information to give in the most authoritative way they can a snapshot of where we are and where we might be and how much we know. Here's a usage of expert elicitation by the Bank of England for characterizing the uncertainty surrounding the future of the British economy. This is a kind of a stomach-churning dip. And actually, if you look, this is the total British economy. If you look at the quarter to quarter, it really looks like a roller coaster. The same paper has that figure. Interestingly, they also show the uncertainty about the past, which is on the left of the vertical line. So we didn't, if people don't know what was happening. It's important to know that people don't know what was happening with understanding how much they might know about the future. Here's a paper that we published about 10 years ago. It was a meeting that my friend Larry Brilliant organized with some public health people and some technology people about how we might deal with Ebola. And in preparation, we asked people to give us estimates based on whatever they knew of the probability of this event. One of the things that people who do expert elicitation do, it's to make it different than just an ordinary survey, is they will ask the same question in two different ways in order to see whether people have sufficiently, people's judgments are sufficiently coherent that if you ask them for a CDF and a PDF, roughly speaking, they'll give you related values. The other book, the Academy, or the National Academy of Medicine, has done a report on uncertainty for pharmaceuticals related to an earlier question. Dr. Relman was involved in this report on the potential risks and benefits of gain-of-function research. I have this paper summarizing things on risk analysis, if that's not familiar to people. So who do we need to execute this program? We need at the least domain specialists who know about all of the aspects of a disease and the control mechanisms. We need analysts who can reduce the fire hose of information that experts are always capable to the things that are relevant to the decisions that diverse people face. And very close. And then we need social and behavioral scientists. We actually probably need people from the humanities as well to understand what are the public's needs so the experts can address them, and then understand where people are coming from. And finally, we need the application professionals who can do the training, get the microphone set up, and so on. And we need a coordinating mechanism so that the communication process can benefit from the insights that people bring from their diverse experience. But in the end, the final authority goes to people within their own domain. So you don't have, as Dr. Rainford says, somebody senior saying, well, here's a teachable moment, and I got to tell people about this or about my own responsibilities. And you don't have a psychologist rewriting the text and introducing errors in order to make it more comprehensible. So what organizational structures do we need to coordinate these people? I think everybody who so we need structures that coordinate professionals with the public, and then coordinate the public among them, the experts among themselves. So everybody who writes on this has some version of this picture that involves consultation with the public throughout the process. This is from our Presidential Congressional Commission on Risks, reported out about 20 years ago. I had the honor of being on I think the first NIM or IOM Committee on Environmental Justice, reported out also about 18 years ago. It had these three critical points for improving environmental justice research. So obviously improve the science base, but then involve the affected population throughout the process and communicate the findings to all stakeholders. The picture that I like the best is from this obscure Canadian document. There's some Canadians here. Here's a redrafting of their figure, which shows in the middle a conventional project development process. I give the Canadians credit for having these little reality checks between the stages. So you may need to go back and repeat the work, or give up if you can't do it. I don't know if you'd have that south of the border here. And they have, but notably, they have risk communication connected by two-way arrows throughout the process. So begin by finding out what's important to people and keep them in the loop all along so that they're not blindsided by what you produce. This is difficult. This requires different kinds of expertise and different processes depending on the nature of the disease and nature of the public, whether people are paying attention to it or not, and so on. But this is the challenge. And finally, what commitments will it take to take advantage of the science, get the people together, and then organize them? So what needs two commitments. One is to evidence, and the second to preparation. So one expression of the commitment to evidence is a volume that Noel Brewer, Julie Downs, and I edited for FDA's Risk Communication Advisory Committee. The formulation that we came up sitting at National Airport waiting for delayed flights was that each chapter in the volume summarizes the science on a particular topic, offers best guesses at the practical implications of the basic science, and then shows how to evaluate the communications, recognizing that the best guess is only that. And without absent evidence, we don't know how well we're doing. So it shows how to evaluate, so talk about how to evaluate communications for no money at all, so there's no excuse not to do it, for a little bit of money, or for money commensurate with the personal, organizational, political stakes riding on effective communication. They're trying, if possible, to shame people into testing their intuitions with evidence. And so the commitment to preparation needs a commitment to preparing for these things. So we're not saying, well, we have to get this out the door because we're out of time. If you're out of time, you haven't done something right. So the preparation requires consultative relationships with the public among the professionals, pre-tested communication modules for different classes of information. So you don't know exactly what's going to happen, but these threats have a particular kinds of recurrent structure, and you could roughly know how to do it and then tailor them for particular nature of the threat. And then you need to have the resources for expert elicitation, message testing, and for tracking the public response. So how do you get that? So one opportunity is to prepare internally. So Noel, Angie, and I were all on FDA's Risk Communication Advisory Committee. There's this is a document that was begun late Bush administration, continued on afterwards, and through the Obama administration, 70 odd steps of FDA, trying to make a little with a lot. FDA has always had a few behavioral scientists internally, and they were trying to use them to make connections with the external world. So there's a statutory risk communication advisory committee that we were on. We have recommendations online for how to deal with the kind of problem that Dr. Rainford first showed, where something's going on and you move too soon, move too late, then people get hurt. If you move too soon, then there's needless alarm. You move too late, then there's also needless harm of another sort, and you're part of a cover-up. FDA has continued recognizing that it didn't know its population, has continued with quarterly voice of the patient meetings where they give professionals and professional advocates, but also patients, an opportunity to talk about what different diseases are. These are very meaningful. If you're interested in just looking at one, look at the one on sickle cell disease. It's these really powerful things that the agency is taking into consideration. Second thing is you could prepare a kind of surge capacity of kind of external resources for people who are not always on the front line, who have the time to think, which is the strategic advantage of we academics, but yet have a commitment to the mission. So I had the opportunity to spend a year at the Medical Research Council Applied Psychology Unit at 15 Chaucer Road in Cambridge. If you read the history of it, it turns out that one of the directors got tired of waiting for the bureaucracy and just bought the building. So there's a challenge to our other administrators here. The APU, among other things, developed the Cambridge cockpit. Let me just say, I was given a few extra minutes of this time, so I'm not just running through a red light. So I will be done on my appointed time. So it developed the Cambridge cockpit, which was instrumental in winning the Battle of Britain. Its model was one where it was led by the top British psychologists, recognizing that the kind of tasks that you all are dealing with are challenging in a different way than the kind of difficult behavior, kind of basic research that we would like to do, and you need the best people possible to do it. It For the staff at the APU, they had incentives to both publish in the top journal, so that they needed to to stay fresh, and needed to look for basic research problems that were embedded in the application. So the applications weren't a tax, but were an opportunity, and they needed to demonstrate their collective usefulness. So the annual report to the Medical Research Council showed testimonies from agencies and stakeholders who said, yes, these people helped us, and along with the list of publications. So conclusion. So we have the science for communicating well about infectious disease, and often do. We'll be focusing on the problems, but there's certainly, all of you have, practitioners have successes to point at, that doing the best that we can, given the science, requires diverse forms of expertise and trusted relationships, so that you can call up somebody who's on the outside and say, what should I do about this? And they'll feel a commitment, and they will understand the intricacies of the world that you all are living in. And finally, strategic leadership is needed to provide the resources and organization needed for routine challenges and for outbreaks. And again, I thank the forum for drawing attention to capacity building and assembling such a wonderful group of speakers. So thank you.